I always think of the NCCN as the universe of options.
Right.
And I'm sure that the guidelines have to be more restrictive than the universe of options. I mean, in adjuvant, adjuvant triple negative breast, there's like 15 different regimens that are listed. And most have level 1 evidence because it's 40 years of history. So I'm curious, typically how many choices will there be that would be equivalent in a category? So if we look at that, first line metastatic, hormone receptor positive, HER2 negative, how many different options will come up? Will all 3 CDK4/6 come up, plus potentially, 2 chemotherapy combination options? How restrictive or how broad is it? And does it come up that you can reference it in a separate way, or just you pick what you pick and then you're told yes or no?
It's very broad. It's basically the NCCN choice of guidelines, essentially, with very few exceptions. Being off pathway, very few that are kind of borderline in terms of efficacy and quite expensive. So no, it's a broad choice, and the on pathway list is long. It's the NCCN guidelines, and then if you need something different, for a patient that doesn't come up in the menu, there's a separate box that you click, and then you can go and search for the option that you need. It's quite straightforward, and like I said, I think it's fine. It allows a good projecting of what costs will be as we need to model what the total cost of care for populations is. But it allows the flexibility which you must have taking care of individual patients.
All right, so Bill, I'm kind of surprised by the description of how broad. It seems to me that even NCCN has come up with preferred regimens, so that maybe a page of 15 that are level 1, but they've identified 2 or 3 that they think for different reasons are best among them. Do you have any kind of mechanism in your center that drills down to a smaller number, a smaller subset that would represent an internal or house guideline or house pathway?
No, I think we're probably that we don't use pathways in our system. So I think, having seen what the reports are that are generated by the pathways, because McKesson and NCCN have a collaboration together, it's fairly impressive. You can see on a very granular level what people are doing and what the costs are, et cetera. We don't have that ability. So I think that's, a problem a little bit. We still try to have physicians be physicians, not to be, abstract artists out there doing whatever they want. I think most people conform to the standards that are dictated by things like NCCN or ASCO guidelines. But to be quite frank, we don't have a way of actually looking at a granular level what each physician is doing. So we have to presume that they're doing the right thing.
And so, Steve, you do have a way, but you're doing it retrospectively, which is kind of problematic.
Well, a lot of our information is limited to the tax identification number. So a large group like the one you were part of, or Bill or Joyce, we are getting individual physician level information with another technology company with which we work in cancer care. So that's being, again, the idea there is to inform that regional medical director type person that Joyce mentioned. So the folks inside of the cancer organization, or the medical oncology, radiation oncology, medical plus surgical in some cases, it's all under one roof. And so that's been helpful. We are also working on rendering physician level through the NPI in our future state. But right now, a lot of our efforts at describing cost are really related to the group level, not the individual physician level. So that is a limitation. And then again, as I said, we do have this one organization we're working with that's helping us to better delineate, but not all the oncology groups have adopted this particular company's platform. So that's, and then the last thing again is that we are on a pathway for all care, not only cancer care, but pulmonary and endocrine and everything else, urological, to be able to be at the rendering physician level, but we're not there yet.